Hi everyone, we're going to be looking at a thyroidectomy specimen, a total thyroidectomy that has a very large lobe and a very small lobe. And so we'll go over some orientation, inking, and sectioning. And so based on shape, we can identify laterality. They've also sutured the right superior pole, so that helps. But if they didn't, we can identify in a relatively normal thyroid lobe, the anterior surface is convex, meaning sort of pointing out at you, right? And the posterior surface is sort of concave or at least flatter because it sits against the trachea. So we know that this is the posterior side. We know that the two lobes are connected across the isthmus, and now you can show my face. In the person's body, it would sit like this, right? With the convex surface pointing outward, the concave surface pointing inward, and the superior pole and the inferior pole. Connected the right and left lobes by an isthmus. And in this case, we also have a little maybe pyramidal lobe or kind of central neck compartment. All right, so now that we have orientation, there's some, I can't tell if those are lymph nodes or pieces of thyroid. Anyway, now that we have orientation, we're gonna ink. So conventionally, we do left black and right blue because your left hand is your sinister hand, so it's gonna be black. All right. So we'll start with black on the left. We generally apply the ink with a Q-tip, or I guess cotton swab, since we don't want to use proprietary names, all over the external surface. Oops. Front and back. In case of thyroid, the location of any potential positive margins is generally not extremely important because they don't go back to that positive margin for additional resection. So whether it's the anterior side, the posterior side, doesn't matter too much. So we ink both sides the same color. However, for ourselves to keep laterality in mind and be able to correlate, to any ultrasonographic findings, etc., we do want to maintain left and right laterality. So we do ink the left and right differentially. And so now the right, the large right, is getting blue. As you may have already been able to tell, this thyroid was fixing in formalin overnight, which is why it's a little brownish rather than fresh reddish, which it would have been if it came directly from the OR. So we saved the inking to do together with you. Normally we ink them fresh, but regardless of whether you ink them fresh or fixed, as long as you ink them. All right. The thyroid doesn't have an actual capsule. It just has a surgical tissue plane. So as you can see, there's fibrous tissue, there's vessels, but there's not an actual true capsule. I'm just inking the surgical tissue plane, essentially. All right. And in cases where the isthmus and or pyramidal lobe is evident, we could choose to ink the isthmus and or pyramidal lobe in a third color, which in this institution we generally do orange. So because we have a little central compartment and or pyramidal lobe, we're gonna just over ink that orange a little bit. So that little guy is going to get orange. You can see that. And we can do a little swipe of orange down the isthmus as well if we want, just for orientation of where the isthmus is. I accidentally got a little bit too much on the black. Sorry about that. Okay. And in order to fix or affix the ink to the outer surface, we use vinegar. Yes, indeed. Just regular old white vinegar. I like to apply both towels and pressure to the outer surface, which I think helps affix the ink, because otherwise it's going to end up all over our hands and surfaces. So let's do that again. For good measure. Unfortunately, it's not balsamic, otherwise we'd all be very hungry right now. Just kidding. We'd have a thyroid salad. You can edit that out, or not. Okay, so we've absorbed quite a bit of ink from the outer surface. And when we pat it down with a towel, you're probably never going to be able to eliminate all of the ink, but at least, you know, it's not super, super wet and drippy all over the towels. Okay, so I think we're potentially ready to cut. As I was saying earlier, boy, I really like to talk about cooking. Just like when I cook, just like when I gross, I like my work surfaces clean and organized. Your mise en place, right? Okay. So the things that we like to do before looking at a thyroid specimen are investigating what the clinical, radiographic, and FNA biopsy diagnoses were. In this case, on ultrasound, there was a nodule occupying essentially the entire right lobe, and there was also a smaller nodule within the left lobe, which we can't really see from the external surface, but hopefully once we cut into it, we'll be able to see it. The diagnosis on the outside biopsy was suspicious for malignancy, or the diagnosis on the inside UC read was suspicious for malignancy. So we really don't know what we're looking at. We have no molecular testing, but we know it's very big. When you're dealing with thyroid neoplasms that are not obviously malignant on FNA, whether they're suspicious or indeterminate, one of the most important ways that we can assess for malignancy in thyroid is by examination of the capsule and whether there's capsular and vascular invasion. So in cases of large nodules like this, we are going to want to examine the tips of the nodules in perpendicular sections and the remainder of the nodule in essentially cross sections. So important things to keep in mind when grossing indeterminate or suspicious thyroid nodules. So yep. So after we have weighed, inked, and measured the thyroid, we're going to bisect it through the isthmus, which is going to be approximately here. And we will deal with each half separately, so we'll put that aside for now. For the right half, as I said, because we want to evaluate this tip of the nodule perpendicularly, I'm going to make my first cut perhaps a little bit thicker than I normally would for just a routine section. So that's going to be our superior tip, and I'm going to lay them out in order. As you can see already, the outer perimeter is more fixed, meaning it's a little more brown, and the inner is a little bit less fixed, so a little bit more reddish. The remaining sections I'm going to try to cut relatively thinly. I don't ever like to keep specimens bookended. By that I mean connected at the bottom end, because you do not get to fully evaluate the entire specimen, except if it's breast and that's a specific request. For a remainder of specimens, I do like to section them thoroughly and completely so that you have full cross sections. I always like to choose a blade that's larger than the specimen. So you're not going to be wanting to saw at this with a tiny little 10 blade, right? You're going to want to use a larger blade so that you get clean cuts. Now we're approaching where we cut through the isthmus, so that's not going to have any ink on it. sometimes the fuzz. I'm encountering a little resistance inside, so there might be some calcification in there. So we don't ever want to leave any aspect of the specimen or any portion of the stone unturned. So you do want to serially section through the entire thing in slices that are approximately cassette ready. We can always thin them down later if need be. Okay, and I'm gonna leave this cap, again, a little bit thick, so that'll be our inferior pole. So we have essentially our in order slices from right superior all the way down to right inferior. So we're gonna take photographs of the cut sections, and we've isolated a solitary cut section. We are zooming in on it as much as we can with the photo stand. So we certainly don't want to be on very low scanning, because then most of our background is filled with dead blue space. And we perhaps don't want to be on the highest setting either, because then our edges get cut off. So we're going to back off until the picture fills the frame, which in this case 80% is in fact perfect. So we'll stick at 80%, and we'll take one photograph with the lights on and one with the lights off. So now we're going to perpendicularly section our caps to verify that the neoplasm in fact does go to the tips of the lobe, which it looks like it does. I do not see any residual normal thyroid at the tip. However, I do see some residual normal thyroid adjacent to some of these sections, as here. I also see satellite nodules, as here. I see additional normal thyroid and satellite nodules. And lastly, we come to our last tip. So we're going to perpendicularly section that as well to verify that the lesion in fact does come to the very edge of tissue, which I believe it pretty much does. So we're going to assume that the tumor spans from the very superior tip to the very inferior tip. So that's going to be our first dimension measurement of the lesion. Our second dimension measurement is going to be the same as the medial to lateral direction, because again, it spans from essentially the entire medial to lateral aspects of the thyroid. So we're going to just remeasure that again. It's about 8.8-ish centimeters. And then the anterior to posterior dimension, again, pretty much spans the entire, but we'll measure that just for clarity, about 5.5, about 5 there. So we've now measured not only the lobe in 3 dimensions, but also the neoplasm in 3 dimensions as well, accounting for a very thin, about 0.5 centimeter rim of normal thyroid in only select few slices. So overall, we have all of our slices lined out, again with our inferior tip perpendicularly sectioned and laid on edge, and our superior tip perpendicularly sectioned and laid on edge. So in the case of a large lesion like this, we are going to submit only representative sections. I would say on average about at least one complete section per centimeter of tumor, so that's about 11 to 12, including any interface with normal, including any representative satellite nodules, and including any areas of heterogeneity or hemorrhage as seen here, or fibrosis as seen here. As you can see, again, the rind is much better fixed than the center. So before submitting these in our racks for processing, after we cassette our representative sections for submission, we're going to let these fix in formalin until they're essentially nearly completely brown. Otherwise, we risk underfixation during processing. And now we approach the contralateral lobe, in this case the left and pyramidal as well as the isthmus. So in this case, we really don't know what's inside because we can't palpate or visualize much from the outside. So we're going to serially section perpendicularly or axially from superior to inferior, with the exception of this pyramidal lobe or central compartment, which I will cut off and deal with separately. So we'll start at the superior left pole, and again lay out our slices from superior to inferior. This is a little bit easier to cut because it's better fixed, so my slices are going to be thinner. I personally don't like cutting on these chucks because they exude too much cottony material, so I like to cut on paper. I see already a nodule coming up. These little guys just kind of fragmented off, so we're going to place them approximately where they fell off. If the specimen is fragile, sometimes there's not much we can do about it. I again see multiple nodules coming into view. Patient definitely has a plethora of small nodules. Okay. All right, so now we have our left lobe from superior all the way to inferior, and we see multiple nodules, including a sort of dominant one here that's a little bit whiter than the rest, that devolves into this kind of nondescript conglomerate of multiple nodules. And if we flip over each of the sides, we sort of appreciate that they are mirror images of each other. So we can see relatively where the nodules begin and end. In this case, it's a little bit hard to estimate because there are so many of them. So in this case, we'll probably submit representatives, perhaps every other slice from superior to inferior.